Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. On today's episode, we are going to take you through one of the issues currently disturbing Nigeria's health sector, and I'm glad to bring on board a good colleague of mine, Mr. Wada Hassan Yusuf. Mr. Hassan, how are you doing?
Yeah, I'm good. It's nice to see you once again.
It's nice to be on this platform discussing with you on Lassa fever, and I'm so glad it's you that it's on board to discuss this. And I'm sure at the end of our discussion, our audience would have gained enough insight and knowledge about Lassa fever, especially in Nigeria. So before we move forward, as we usually do, let's give our audience an overview of the profile of the guest researcher for today. Mr. Yusuf Hassan Wada is a pharmacist with a long-standing commitment to global health and leading partnership buildings that align with UHC and SDGs attainment. Presently, he serves as a Policy and Advocacy Officer, African region with the Society for Family Health, coordinating SFH policy positions at regional, national, and subnational levels on health system strengthening initiatives. He holds a bachelor's degree in pharmacy and a master's in public health. He has additional trainings with the Lagos Business School, National Institute for Policy and Strategic Studies, and the University of Washington, and has received an IAS Advocacy I believe it is an IAS International Aid Society Advocacy Fellowship in South Africa and Canada. Since 2022, he has served as the co-chair for the United States National Institute for Health, Martin Delaney Collaboratory, and as a member of the Committee Advisory Board for John Hopkins University-led research consortium in finding HIV cure in the pediatric population. He authored a book, Intentionality, and published over 30 research papers in high-impact peer-reviewed journals, including The Lancet. He also has presented research output at various local and national conferences across 4 continents in the world, including the 79th and 80th session of the UN General Assembly. Beautiful profile, Mr. Wada. I really admire your artwork. I really admire your impact on not just Nigeria's health sector, but on global citizens. And I don't know where because I know you are my LinkedIn connection, but I don't know where we met. Maybe at the West African Institute of Public Health, but it seems you have a story at the West African Institute of Public Health. It seems you are the first person to ever go through the virtual internship program, the HLLP, and the what's the last one? Is it DL Fellowship, something like that?
I think that's the VIP, the virtual internship program, then also the YLLP, the advocacy part, and also the DIL Fellowship that deals with leadership, design, equity. Yeah. So I was the first to actually go through the training.
Beautiful, and that's beautiful to see, Mr. Wada. Before we dive into the discussion, let's see what global citizens are saying about currently Nigeria. I know Nigeria once in a while. Currently, we face Lassa fever surges, but currently, what are people saying about Lassa fever? The NCDC tweeted about a day ago. They said Lassa fever is preventable. Protect yourself and your loved ones by keeping your environment clean and rodent-free, and storing food in tightly covered containers, washing hands regularly with soap under clean running water, seeking medical care early if you notice symptoms. Together, we can reduce the spread of Lassa fever. That's from the NCDC. The second tweet is from Adedayo Makinde, where she said, while terrorists are attacking Nigerians in several states, diseases we had conquered previously are also quietly fighting us. Is there anyone else following the Lassa fever spread all over Nigeria? We are just focusing on insecurity now, not knowing that Lassa fever is also spreading across other states in Nigeria. As we are facing insecurity of physical insecurity, we are facing disease.
The health security architecture is actually in also in some disarray, in the sense that it also poses a very national security issues. Particularly, we saw how COVID really show how vulnerable, how diseases can really vulnerable to many issues.
Exactly. The last tweet is from Bodataye, where he said, 3 weeks ago, I was admitted to the hospital, had consistent fever, and the doctors lied to me, moved me to the viral diseases center to test without informing me, quarantined me because they suspected I had Lassa fever. I read about it and started crying. It came out negative. I don't know which hospital is that, but I believe every patient should be informed of the tests they are going to undergo and the places they are going to be taken to. They shouldn't be taken to any places. They shouldn't be tests shouldn't be carried out on them without being informing them. Consent is needed, and that's why a patient like this Bodatai was crying when he found out that seems he had Lassa fever. So that's interesting to see. So let us dive now into our discussion on Lassa fever. One of the things I was scared of because I went to boarding house in secondary school. One of the things I was scared of having is also Lassa fever, rats eating my leg.
So you took some
I don't know. Personally, I've never seen anyone who rats eat their legs, but they say rats eat legs at hostel. So when I came across the paper, it was actually mind-blowing for me. Actually, I didn't know Lassa is a town in Borno State. That's where they got the name from.
Yeah.
It's from your publication I understood that actually Lassa is a town in Borno State.
It's from there.
Yes. Yeah, and it was given the name in 1969. I believe this is something that many people don't know. And also Nigeria bears the highest burden of Lassa fever in sub-Saharan Africa. So, diving into the discussion, Mr. Wada, what are 3 things? Because I know there are many things, and that's why we encourage people to also watch this video and also read the publication. What are 3 things you want us to know about Lassa fever?
Okay, thank you so much, Azeezat, for having me once again. And just like you said, the last tweet said this all. Many people would like to know what's really happening. Many people doesn't even know on diseases that is endemic in actually our country. And there are quite many of them. When you look at the situation report from NCDC, for example, every day you see new diseases that have actually been part of our health security burden. But just like you said, 3 things. I might say 10 things, but I will make sure I will be within those 3 things. The first key thing is actually Lassa fever is a persistent seasonal zoonotic threat in West Africa, and majorly have regular outbreaks in Nigeria and also in multiple West African countries. And when you look around the prevalence, it actually causes annual outbreaks that actually occur mostly in seasonal timing. So what does this mean? It means that Lassa fever is actually zoonotic, transmitted from an animal to actually human beings. So when you look at that, it actually tells you how do you control those vectors, how do you control those animals to not to transmit those diseases. But it have actually been also reoccurring every year and putting burden in our health services, our security architecture, money that could have meant to actually go, for example, economic strengthening, for maybe insecurity might actually be involved into those things. Or just looking around the prevalence, looking around the paper might be 2 years old, but even at this year, I was actually looking at the situation report some 3 months ago in September. 176 people from 21 states in Nigeria died from Lassa fever in 2025 in the first 9 months. So this is a data from NCDC, and basically, like many lay people will say, oh, this is not the whole number that is captured. So when you look around the total number, almost 176 people died. It's actually higher than many diseases in many countries that they take it as a disease of importance. And also when you look around the overall data, 955 in September, that's close to 1,000 people who were confirmed to have a case of Lassa fever when they suspected over 9,000 cases. So that tells you that the even incident rate is actually very higher. And also the fatality rate is higher because from 955 confirmed cases, you have 176 people died. And also it's actually spread so easily because you could see in 21 states, 21 out of 36 states is actually huge. But also moving out of Nigeria, this disease is not endemic only to Nigeria, but it's endemic to the whole West African countries. Benin actually reported a case this year. Ghana reported a case. Guinea reported a case. Liberia reported a case. Mali reported a case. And Sierra Leone reported a case. So when you look around, it's not a Nigerian problem, but it's actually a whole regional problem that we still have. So I don't think there's any country that haven't reported a case, maybe from West Africa. But maybe when you look at a deep dive, you could actually see maybe who take the highest burden, which I felt Nigeria have. The second thing I could actually say is that this Lassa fever is mainly driven by rodent to human spillover. So it's not a person-to-person transmission, just like we have HIV, like monkeypox. It actually have a vector that really transmits human. So what does this tell us is that preventing these infections means that we need to address our household and environmental exposure to rodent. So not only clinical care could we do, because basically when you talk around the likes of HIV, they'll tell you that you need to have a safe sex, you need to not share needles, you need to actually prevent person-to-person transmissions through so many ways like fluid. But this is actually transmitted from that rodent to human spillover. So that tells you that we have a bit control over it by addressing those environmental exposure. And just like you said in tweet, so many times you see even now on social media, people doesn't hide that they eat rat a lot because basically before it was something that you see in actually the street. But people doesn't hide it anymore. You see people say, oh, I eat the rat, I do this. But basically they don't know how they have been exposed to a disease which is highly fatal. The third thing I could actually say, it's actually from our publications and it's something that people doesn't know much. Health system readiness, I think that's what really our research was talking about, and also workforce knowledge. Because basically what we felt at that time was that many people have actually go to do studies, knowledge, attitude, and perceptions. Our own didn't want to do knowledge, attitude, and perception, but also to know what is really the knowledge gap. What is the even overestimation of competency? What is the underestimation of competency? So we didn't went to what the normal GST, the general things people do. We actually went to look at the whole system. Is it ready? How competent they are, and also tell us the knowledge you have on Lassa fever, so that we can estimate, is it that you are underrating yourself or you are overrating yourself? So that's really what we do. And plus really gave us a platform to show that even those healthcare workforce, those healthcare workers, they have a knowledge gap, and there's actually an overestimation of their competencies, because those gaps directly affect those transmission and also case management. So when you go to a hospital, someone tells you, oh, I know how to manage Lassa fever, but what is the first line treatment? He doesn't know. So we actually highlight those things and also tells how do we improve those training and also those IPC, and also how do we even protect our first line workers, that's our healthcare workers providers. And that's really what the whole overall publication was all about. So over to you.
Thank you so much, Mr. Wada, for summarizing what we should know about Lassa fever on that 3 main points. And I feel you did an excellent job on that. One thing is, I mentioned earlier, when I was in boarding school, I used to be scared of rats eating my leg. And growing up, I used to have some people who eat rats, like some neighbors who used to eat rats, and you mentioned rodents in your speech. So I want you to elucidate for global citizens what animal specifically is responsible for Lassa fever.
Okay, basically, there's actually an animal we call rats. It is the name, but it actually have also a special breed. So they call that rat multimamate rat, and also the scientific name is Mastomys nathanensis. So that's they often call multimamate mouse or rat. I think that's the literal name. So it's actually most time the normal rat we see, but it's actually a special breed. These rats live very, very close to people. And rats are very stubborn. Their main key thing is actually how do they disturb you? The main cloth you have, the main good food you have, how you preserve it. Their own is actually to contaminate that food and surfaces. And they don't contaminate using maybe, let's just scatter it. Basically, they actually excrete those particles through their urine and feces, and that contains a viral which is circulated. So basically, other rodents carry what they call, I think, Lassa virus. They actually do, but this Mastomys virus or feces, or let's even say the urine, contain a heterogeneity. So what it means is that it actually behaves the same way, so that the transmission intensity, the reservoir dynamics are almost the same for all of them. So when they do, it actually get into the system and they begin to replicate. I don't want to go into sciences, but what virus means, even virus is actually a microorganisms. We have many of them. We have the virus, we have the fungi, we have the bacteria. So virus is actually one of the most stubborn. Sometimes people equate it with fungi. So HIV is a virus, monkeypox, there are so many of them. Well, what really happens and why viruses are very stubborn is that when they go into the system, they replicate. I know it's science. It's go to the DNA, replicate, and causes so many things like that. But when you take the feces or when you take the urine, it actually sustains that viral circulation in your body so that it can cause what we call an infection. So that's when you feel you have fever. That's when you start to have those feelings. But basically what that animal that is responsible, you can only do is control those environmental hygiene. At your home, you clean surfaces. When you want to eat food, you clean it very well. Though some viruses are stubborn. There are some viruses when we were in school, they told you that even if you wash, you do this, it's actually stay. And even the likes of HIV, you see how they are. You see blood, it comes out very virulent. So what you do is actually you can only control how those hygiene are, and also control your environment so that you can control rodent, because basically it's not written in the face of the rat to say, oh, this one it's actually Lassa fever containing, but it's actually to sustain, not to do those things. And also people who eat it, people doesn't cook, doesn't do this, you can actually eat maybe where the virus is replicated. So those two things, when you do, it's actually to prevent the rodent completely, and also try as much, even in your environment, your food, not to allow any rodent like that to actually contaminate those food or surfaces.
Thank you so much, Mr. Wada, for shedding more light on what type of rodent causes Lassa fever. Now, quoting from the publication where you and other authors said heterogeneous neglected zoonotic disease of the tropics. People termed Lassa fever as that. What does this mean?
I think in that publication and in many publications we do, it's actually how do we simplify language. And I could remember I actually went for a fellowship in South Africa, in Canada, and also in US. How do we simplify languages? Because most times you actually went to publications, you write articles, you write so many languages that even your community doesn't understand. But when writing these publications, that heterogeneous, we were thinking, oh, do we use a normal language? But peer reviewers are also sometimes stubborn. They will tell you, no, this is not a scientific language. So I think we had a back and forth and also maintain that heterogeneity or heterogeneous zoonotic disease of tropics. So what does that mean is that it's normal English word. Heterogeneous means not the same. So it means Lassa fever doesn't behave the same everywhere in the world. So what you could see in Katsina might actually be different from what you see in maybe Kwara, because it actually might not be the same rodents. Maybe even when you see, even in the same family, in the same scientific class, they might be units of different. So one of the main issue we think was that it has actually become a neglected diseases because the transmission intensity, the clinical severity, the reservoir dynamics, and the seasonality varies across region and even states. And I actually was looking at data, like I told you, in September. The situation report of Lassa fever is that how it behaved in Kogi state was entirely different in how it behaved in Kano. So neglected also signals that historically, when Lassa fever started, for example, in Borno State, it received less research, it received less funding, and it received less political attention than other threats. And you actually alluded that it was unraveled maybe in 1960s. So imagine a country, or we are actually talking about diseases that since 1960s people doesn't know it, and it comes every year. You just said maybe you haven't had a lot. That's you being scientific and being curious. I can tell you, when you go to the street, ask people what's Lassa fever, they don't know, because it has not been given attention. I do tell people, we saw how COVID, because it was a disease of attention, not because it was a pandemic. What I felt, if it was a disease is only maybe in our region, maybe it couldn't have gotten that rap attention. We saw how vaccine was accelerated, given an accelerated approval. We saw how even the likes of Marx, we saw even journals, big journals, given free APC for over 2 years when you want to publish COVID. But Lassa fever haven't really gotten the political attention it needed. And also, when you look around zoonotic diseases of the tropics, what it simply means is diseases transmitted from animals to rodents, from animals, that's the rodent to humans, are found in the tropical West Africa. I told you the countries, over 7 or 8 countries have actually had consistent outbreak of these diseases almost every day. Every year they do have it. So basically, in practical terms for Nigeria, it means that diseases require tailored approach locally. It's cross-sectoral, and one thing that I do tell people is not a disease that you say, oh, this is COVID. It's actually an NCDC work. It's not really an NCDC or Ministry of Health work. It's cross-sectoral, and maybe you have heard of this term, One Health every day, in the sense that it's something that we need a joint approach. We need the Ministry of Environment, because they have a lot to do with what they call the forestry, the farming. We also have Ministry of Agriculture. We also have even animal husbandry. I think there's a new ministry related to that. So that response as a country require a response that is not one size fit all approach. It needs everyone coming together. It needs everyone to actually say the same language. And it needs that sector-wide approach because of that heterogeneity, because it doesn't behave the same everywhere. So we need to have a sub-tailored approach for a country like Nigeria to even look at its clinical severity, its dynamics, because I am very sure that these diseases might not even be adequately diagnosed. We are actually, from the research, you saw how we actually reported that there's overestimation of knowledge and competence. People feel like they know, but they don't really know what Lassa fever is, because we actually went to the guidelines, we pick questions, ask them, they say, oh, they know it. Tell us what you know, but not really there. So it means that even while we do training, maybe people haven't really think like, oh, this is what it is. And that's also one conversation maybe you might really want to, maybe in your subsequent interview, is that Nigeria is actually looking around a sector-wide approach. One plan, one message, one day. So how do we operationalize that is also something, because we have seen in many researches that many training happens which are contradictory. So that's really what we feel, and that's what we think from our researchers can really help. And this is something that has been done 2 years. We are starting to talk about sector-wide approach and quite a lot of new languages now, or tailored, sub-tailored approach. But we have actually looked at that and also reported how those things could be done. So over to you.
Thank you so much for simplifying that, Mr. Wada. One thing is, you said it's simple words, but because you're a researcher, to you and other researchers, it might be simple words, but for people outside the layman, it's not, they are not simple words. One thing, since I started this platform, one thing that I've understood is people, those as people don't know, because in one of our previous episodes, coppers, there are coppers, there are people who are coppers, and they've never heard of breast cancer before. So you can imagine someone who went to school degree 4 years or 5 years. I don't want to assume they are medical doctors because they can't be pharmacists and doctors. But yes, someone who finished, yes,
yeah,
4 years degree, let me put it that way, excluding the strike, and they don't know about breast cancer. Just breast cancer, and this is, you understand? So you can imagine.
I understand how it is. Yeah.
Exactly. So thank you so much for simplifying that. I want you to take us through what is happening in Nigeria's health sector. Is Lassa fever as a condition? Is it eradicatable from Nigeria's health sector? And what is the reason for your answer?
You want to put me on a hot seat? I think realistically, as a person, I felt as a country, we're actually trying to be on the right path. And like I said earlier, the country is actually on the right track, looking around strategy, looking around plan. But for me, translations have often been very low. So many things are happening very fast. When you look at the minister, very strategically, he has even lifted the health sector, never ever before. He has lifted the health sector to actually be in conversation, not only even as a health, but also as an economic uplifter for the country. And I felt with more translations, I mean from strategy translations, plan translation, impact translation, we could actually uplift the health sector and also help the community for whom we serve. Coming back to your question, how realistically we can erase Lassa fever in our health system forever, I think it's actually, we have seen the likes of polio, we have seen the likes of malaria, we have seen the likes of many diseases that have been eradicated in many countries. And I was at the World Health Assembly in Geneva in May. We celebrated 2 countries that has eradicated diseases of even concern, malaria and quite a lot. And it's something that I felt Nigeria could do, but realistically, we're not there. Complete eradication from the health system in Nigeria is not really achievable with the current tools. I said this with the current tools because if we have the world is dynamic. Tomorrow you could see we might really have something, a vaccine or something like that could really eradicate it. But with the current tools we have currently and the current approach we have, I don't think it's really achievable. When you look around Lassa fever, how it circulates, it's actually circulate in wild rodent populations across wide ecological zones. So it means you cannot feasibly eliminate the reservoir because I told you how those rodents live freely. They actually replicate in bushes, in our drawers, in our cabinets. So eliminating the rodent is the first important thing. And I don't think with our wide ecological zones we could do that very easily. Uh, However, I think I'll put this caveat that, however, as a public health problem, if I say as a public health problem, I mean when you look around the prevention of outbreaks, when you look around minimization of diseases, of deaths, mortality, when you look around protecting health services, it's possible. I think it's possible when we put sustained investment. I mean sustained investment in the sense that if we put issues around improving housing and sanitation, Ministry of Environment coming, we activate our health promotions, we activate a very strong surveillance, I mean end to end. When you look around the whole value chain of strong surveillance, we also need rapid diagnostic. And basically, what we felt is that the current diagnostic doesn't work because it requires, for example, gene expert. You know how viral diseases are really done, very expensive. Is it something the country could do? But what we have seen, the trend is that so many countries actually go for rapid diagnostic. Now, rapid diagnostic is that, is it sensitive? Is it validated? We saw how HIV also, to an extent that before people doesn't want to do a rapid diagnostic, but we now have a very validated rapid diagnostic that you all need confirmation to go to the hospital to do some molecular testing. Uh, the other thing which our paper really flagged was trained workforce, because our workforce felt that they are overcompetent to actually handle Lassa fever, but in real sense they were not. The other thing is even effective therapeutics, vaccines. We saw how even the whole of viral is actually something I have actually invested a lot of time to do it for like 3, 4, 5 fellowship, also in the US. Every day we actually sit down to discuss with them. They actually discuss around how stubborn it is, because it actually have full circulation, not only in the liver or kidney, how some are, but it actually goes to every tissue, to every saliva, to anywhere to keep replicating. So even to find out how to eliminate it, it's something. So how do you find those effective therapeutics or vaccine? And also to be available. We have often see how skewed it was for a place or country to have this and not to have that. So I think that's also there. Routine community engagements are very important too, because it's actually where people understand how things could do. I don't mean only on the supply side, but also on the demand side, because government feel like, oh, let's just talk to them. But basically, routine community engagement is not really about talking. It's not really about how utilization has been. And I give example in this. We have actually been doing, for example, malaria nets program, community engagement, where utilization level has actually been very low. Same thing with HIV. When you look around the whole messaging, but still people feel like, oh, it's more sweet to have, for example, unsafe sex. It's more good to have this, but they don't really look around the rifle effect. So sustained routine community engagement is very important. And just my last point. So the realistic goal for Nigeria is sustained control and resilience rather than to go for biological eradications. We will spend a lot of money there. But I felt with our little we have, we can actually realistically go for a sustained control and also release health system resilience, so that we can actually provide an elimination as a public health problem. Then we'll start thinking around how even we could do eradications more possible. But we need to invest in those things I have actually listed. So over to you.
Thank you so much for that, Mr. Wada. Actually, from my perspective, you asked me before, after reading the publication and before listening to you, if you ask me, I'll be like, Nigeria sector actually we've perfected taking care of Lassa fever, we've perfected management of Lassa fever. But now you are saying that, oh, you feel like, from your perspective, that you feel like we are overcompetent, but rather we are undercompetent. And this takes me to the next question of Lassa fever being a burden currently on Nigerian health sector. Do you feel as an individual like the past management of Lassa fever over previous decades Has there been any change between the previous decades and future decade for management of Lassa fever in Nigeria? What has changed? What has been done in the management, and what will change in the management of Lassa fever in the next decade?
I think a whole lot has changed. When you look around, the case detection, surveillance have really improved, maybe in the past decades. We have actually been, as a country that doesn't even have a national surveillance system, to even have a situations analysis. I think for every week, there's actually a national surveillance analysis that shows how frequent situations are reported and how detections and even the mortality. So I think that's really something. We have actually improved more on those data, this aggregation, to say even this state have this state have that. But I think those can even be improved. Looking around, also the prevention, control, and also awareness and training has really expanded. Especially when you look around, there was large outbreaks that have really affected healthcare workers, but it has actually reduced. So before, we have seen how even infectious diseases have really affected majorly healthcare workers due to handling issues, due to infection prevention and control. But there's actually more gains in that aspect. And even our study shows that these gains remain even uneven across facilities. So how do we check what's really the issues, and also to see how best possible to checkmate them, to also see who is lagging? Like I said, we actually need now a subtolerant approach. We don't think there are states that we felt they don't need those approach or they don't need those ratings. So which state are lagging, which state needs more input, which state need more investment. So those key things I felt has really changed. The third thing I felt has really changed is diagnostic and lab networks have gradually expanded, at a point that even as Nigeria, we don't really have diagnostic and lab network that can really transmit surveillance and case detections in real time. Because I knew in the past 10 years, there was a time that before COVID, not even 10 years, before COVID, many states doesn't have a PCR. When you have any viral, they take the sample, take to another neighboring state or even far away. And we even saw it in COVID. Many states couldn't even diagnose COVID. They normally send it to, I think, a lab here in Abuja or even Lagos. But we have seen the private sector has actually stepped up. We have the likes of Gene 54 and many others coming in. Even the public, we have seen at least a tertiary institutions in a state must have those robust diagnostic and lab networks, not only to test, but they can also send signals to the national dashboard or to the national surveillance system. I think even the turnaround time has improved. Before it was very late. It takes 2, 3, 4, 5, or even 7, 2 hours to actually transmit those turnaround. What we have in the sense that in few minutes, those key things can actually be validated. Genomic coverage is something I felt it has remained limited in many areas. I think that's really what has changed in the past decade for me in Lassa fever and also overall infections prevention in Nigeria. The next decade, what I felt should likely change is that there's actually issues around therapeutics and clinical trials. Therapeutics and clinical trials need to actually be uplifted. Nigeria now hosts new treatment trials, and I think the first large Lassa trials in decades is actually happening in Nigeria, which could even change the standard of care if new drugs or even combinations Prospero to ribavirin. I know there's actually even Danfodio and also Form. They're actually looking at that. And also looking around better diagnostic, I felt, and genomic surveillance, like I said, we need to be better. I expect more point of care near patient testing. So even local government, primary healthcare should have a point of care just maybe some preliminary testing? Is it RVGT or other things like that? And also we can expand our sequencing capacity that will improve our case informations, case confirmations, even detect new lineage. Serial testing we do basically have been hectic, and also it's more like institutions does it now. And also, how do we inform outbreak response? We actually wait for the center to do everything for us. I felt also the last thing we can also do is actually stronger One Health programs and community interventions. I felt on paper we actually have that, but it hasn't really translated to actions. Our stronger One Health approach has not really been enough, and community interventions have really scaled down. So how do we scale rodent control is important. How do we ensure waste management and risk communication is very important. You actually talk around tweets that actually have think like, oh, it's actually a death affairs or something. So how do we ensure that even our risk communication, particularly when there's high epidemic, how do we provide a risk communications? Because these upstream measures are only sustainable way to reduce spillover of those virus. So I think overall, incremental or meaningful shift are really needed. We need to move from a reactive case care to integrated preventions, earlier detection, and also improved therapeutics as a country.
Thank you so much, Mr. Wada, for that. Thank you for taking us through the journey of Lassa fever in Nigeria, what we've been doing, what we're currently doing, and what can be done to improve our management of Lassa fever as a country. Mr. Wada, we have on Lassa fever from the paper, there is a gap. And not just on Lassa fever, but we are focusing on Lassa fever now. There is a gap on awareness and knowledge on Lassa fever in Nigeria. What can relevant stakeholders do to bridge the gap?
Wow. I think stakeholders as a country, as a community, as also healthcare professional, everyone can play his part. But I will actually give 2, 3, 4 to actually tell you targeted of what I felt on the short and long term will really help. I think the first thing I'll say is that we need regular competence-based healthcare workers training. And most times we felt training are just there to get per diems. Trainings are just there to just have the certificate. Trainings are just there to just do it. We felt like, oh, sometimes when you come train me is that, oh, there's actually infection. Why are you doing this to me? Go and talk to people, maybe an infectious disease or something. But even an obstetric nurse or gynecology nurse who is actually in the hospital, she need to actually have that training. We need to actually take it as a whole of approach. Is it on diagnosis? Is it on infection prevention control? Is it on donning and doping? Is it on even triage? And why I said this triage, I wouldn't like it to actually escape my mind. I could remember a case that happened. Is it in Lagos? When triage was trending. When I think a celebrity was saying, I couldn't remember the story, but it's actually stick to my head. When triage was something, they were saying, no, it wasn't correct. The state government was saying even healthcare workers were talking around. I think there was an accident or something like that when triage was done in an open space. People were just criticizing. I felt like, oh, even healthcare workers doesn't even know how it is. So we need that retraining and training and even on learning, on training. So our study shows that training status predict knowledge. So if people are more trained and also evaluated, it predict their knowledge. So routine in-service refreshers for maybe someone that came from school, his triage or even donning dolphin training or even IPC must have been something he has learned from, let me say, he has gotten from maybe OSCE that he has been afraid from internal medicine. When maybe a professor is actually telling him not to do, he's actually on he's anxious. So sometimes we actually things that they know, but we need to do those training, refresher training, simulation also. I felt simulations are really important because sometimes people you tell someone, oh, there's an online course, just go and do it. You just put it there, just click. When it finished video, it shows 60% and he has passed. So I think we need to we need to do simulations. We need to do competency checks. Who are people who are good in that aspect? And I know from medical school, some are really good in handling infectious disease. Some doesn't want it. They feel like it's actually something. So I felt that's really one. The second thing, like I said earlier, is actually targeted risk communications and community engagement. The world has actually moved like, oh, there's actually Lassa fever. It stayed, communication stay in that aspect. In Kogi, for example, if there's Lassa fever, before it actually stay within those public health department, no one knows they actually try to do. Today, if someone has it, he will just put it, oh, there's actually Lassa fever in Kogi. Don't follow maybe Kaba, there's Lassa. It's not something that it can't reach you because of person or something like that. But it needs people to engage community, to use local language, to use trusted community leaders, to use media. Is it tradition? Is it the normal media? To address misconceptions, very important. To promote rodent safe food storage and also food hygiene or household hygiene. Very important, because many people feel like, oh, Lassa fever, you tell people, they feel like it's one disease you go and get it from maybe sex or something. But it's something that even how you actually react in your environment, your kitchen, your stores, it's really very important. The third thing very quickly is actually strengthen pre-service curriculum. Is it in training? Is it post-training? Is it in our own public health training? We need to include Lassa fever and viral hemorrhagic fevers in medical, in nursing, in public health training, so that new graduate enter the workforce very, very prepared. The fourth thing I've said it quite enough. I think One Health coordination, very important. We need to fund cross-sector surveillance, not only as the health, but as also human, animal, and environmental work. So messaging should be One Health, so that Ministry of Agri, Ministry of Environment, Ministry of Health, and quite a lot of them understand how it's actually a national threat. It's actually in the national interest that it can actually disrupt our whole plan for our well-being. And also actions plans should be aligned, should be smart, and also should be timely. And I think we need to invest in diagnostic and lab turnaround. How does even local government communicate very sharply to state, or even go directly to national? How does even state go directly to national? Also, even our regional bodies, sometimes it's actually how we do. And that really provides confidence for those people in messaging and also reduce those notosomial risks. The last thing I will also say, it actually have been escaping my mind, but I think it's actually around auditing and feedback. So most times when we do implementation or we do some work, we don't really look around feedbacks. We don't really look around auditing our loop. I think our messaging back, our feedback mechanism. So how do we implement auditing how healthcare workers are knowledgeable? How infection prevention control practices can actually really help with rapid feedback? How does even on-site coaching? Our paper actually recommended a lot of them. How do we even personalize feedback strategies to people that you are not really competent enough? There are so many strategic ways to do that. We can actually even have tailored trainings. So those are things I actually felt that will really help. There are many of them in our paper, but I felt this will really help us to actually contain this Lassa fever and also other viral hemorrhagic fevers.
Thanks so much, Mr. Wada. You were speaking. Me, I saw an honorable Minister for Health speaking. Okay, thanks so much for the great recommendations. I'm very sure if our stakeholders, as this video is cutting across their faces and their social media, they are getting the needed recommendations also to implement to help Nigeria, because we have recurrent Lassa fever outbreaks, and currently we are facing a Lassa fever outbreak, and that takes me to our next question on management of Lassa fever in Nigeria, which you've given a hint so far in our discussion from previous questions. Where is Nigeria currently on the management of Lassa fever from 1 to 10? And what is the reason for your answer?
Aziza, you are setting me up too much. But I think I will give it a straight half. I will give a 5/10. My reasons could be Nigeria has actually built surveillance and response architecture. And like I said, NCDC leadership has really, really been very important. During the likes of Chukwe during COVID, Nigeria was actually one of the top 10 countries that have responded to COVID very well. So I think that's really helpful. Nigeria has also a multi-partner groups or people who are ready to support. And I think this comes as a country, as a region, not as a country, that even African CDC have really stepped up in infection prevention control. I could give them. I actually have my reservation on the regional part because we haven't done enough on other diseases. But when on infectious diseases, they have actually been consistent. Like I said, we are currently hosting therapeutic trials with, for example, the VOM, the National Institute for Veterinary Research, doing some therapeutic trials. And that's a very clear positive steps for the country. But also on the other side, which actually gave me a reason to say 5, it's actually, as a country, we have persistent problem. We are actually talking around healthcare workers' knowledge. We are actually talking around infection prevention capacity. We are talking around, we have variable diagnostic access. We are talking around lab turnaround in states or even in local system is very low. We are talking around gaps in community preventions measures. We actually, as a country, even in the Africa region, we have a very low housing sanitation issues. When you look around, even our own wash standard, very, very low. And we are also, as a country, talking around safe water yet. We're talking around safe food. We don't really have. And also, I think the last thing is we are talking around continued high case load. This is a disease since 1960s, but we are also having over 167 people dying from a diseases that can actually be preventable. So even our research actually shows those issues are very real. In all of them, we actually show. But like I said, our paper was actually more of healthcare workers' knowledge. So even our research shows that even those knowledge gaps were very, very real and may likely impair responses if will be left unaddressed. I think that's really what we said. But as Nigeria, I think we're on average compared to a decade ago. I could say 2, 3, because even a decade ago, we don't really have a national surveillance system. It was just a department or a unit, not a department. It was a unit domiciled under the public health in the ministry. It's more of coordination. But we have now an agency with a full mandate, with a full clear rules on what to do on actually disease control. But still, an important system need to be addressed, and also our community gaps need to be closed for us to even achieve a higher rating. And I hope maybe in the next few years, we can actually say we have moved from 5, from my own personalized 5 rate to maybe an 8. I think it's something I hope in the nearest future to do.
Thank you for enlightening your personalized 5. Yes, that takes me to the next question, Mr. Wada. Let me quote from the paper that Lassa fever is the most frequently imported viral hemorrhagic disease to non-endemic settings. What factors contribute to this?
I think I have been anticipating this question because most times when someone asks you about Lassa fever, he actually tells you, although we are trying to actually be non-scientific here, but actually someone will ask you, what is the incubation rate? What is the transmission rate? What's this and that? So that really gave us why I said this. I think when you look around Lassa fever, we said it's actually a viral hemorrhagic disease. And like I said, we have the likes of Ebola, we have the likes of We have the likes of Ebola and many diseases that are really hemorrhagic and also to non-endemic. What I meant with that statement was that when you look around Lassa fever, it's mostly free, it's mostly important because a rat can actually move from here to here. He can move from, you can see the transmission. They actually, I don't know, and I can't remember how their reproductivity rate is, but it's actually very, very high. So also looking around Lassa fever, look at the incubation rate and also the travel pattern we have. Lassa fever or Lassa incubation is typically 7 to 10 days, and in most times, some studies have shown even up to 21 days. It means that infected people can travel internationally before symptoms start, and air travel from endemic countries or regions could enable that exportation. For example, I actually maybe have interactions or have what's the right word to say? Maybe I have Lassa infections today. The main key thing it means is that it can keep replicating. That's the incubation period. From 7 to 10 days, I won't have symptoms. Even sometimes 21 days, I don't have symptoms till 21 days is started. So maybe today I'm actually in Nigeria, I actually travel to maybe the US. I won't be detected, nothing. I won't have symptoms. So after 21 days, I take it to that country and the transmissions continue. So I think that's what I mean. The second thing is actually when you look around, even in the Africa region, West Africa is one of those regions that have the highest number of populations, and it keeps increasing. In Nigeria, many people or many studies say we are 230, 220, 200, 250 million people as at now. But I think the consensus has been we're over 200 million people. So that means that even as Nigeria, we have a very large number, a large endemic. We have seasonal outbreaks in Nigeria and in West Africa, which really increase that absolute number of traveler cases. So someone comes to Nigeria from US, maybe for the December. He actually went to eat maybe things that has been infected with Lassa fever. So he could actually have it very easily, and it's actually something that he could actually get it. And maybe when he also look at his travel rate, he couldn't even imagine why he got it. Maybe he has traveled a lot of times. The third thing is actually around clinical similarities to other illness that are very febrile. So when you look at it, it actually have the same pattern with the likes of Ebola, the likes of maybe monkeypox. So you could see it has an initial mild non-specific symptoms. You don't feel anything. Then it leads to maybe a misdiagnosis until you travel. You feel like, oh, it's jet lag. Many of us who travel a lot, we feel like sometimes when you have fever, it's jet lag, but we don't know what is really precipitating the fever. So sometimes it started like this. So you can't really say, oh, this Ebola, oh, sorry, not Ebola, this Lassa fever to manage it. Because you start taking maybe acetaminophen or some things, but it doesn't really deals with that. The last thing I could say is actually looking around global motility. Global motility and migration, in the sense that Nigeria is actually a population that is very highly mobile. You see people migrating almost every day. Healthcare workers, business travelers, humanitarian staff, we have them a lot in the country. So they move from between endemic and non-endemic countries. So all these factors combine to make those non-aligned importations more likely from some other viral hemorrhagic fevers. So some you see it actually comes out very easily, then things just goes off. It actually just went off. But this is actually something that takes time. It gives you ample time to actually even take a sporadic importations to other countries or other locations without left unseen, or to even know that how do you kill the vector, or to know how to trace the vector. So over to you.
Thank you so much, Mr. Wada, for elucidating those factors and for highlighting that it's December, and this is a medium to tell everyone coming into Nigeria that Nigeria is currently facing a Lassa fever outbreak. Coming to Nigeria, you should be careful what you eat, the preventive strategies for Lassa fever. so they didn't take Lassa fever to non-endemic areas. Mr. Wada, we've been discussing Lassa fever, and I'm so happy with our discussion so far. I believe everyone, even someone who has not been in the Fawassomi classroom before, if they listen to this, they understand what Lassa fever is, the journey of Lassa fever, what is happening in Nigeria with regards to Lassa fever. What is viral hemorrhagic fever? Because we keep explaining that if anyone, our learned audience, you don't go back to the paper and read the paper, like what are people talking about this sentence, and that's what this platform is for. Basically, what is viral hemorrhagic fever? Because it's big grammar. To us, it might be small grammar, but to other people, it's big grammar. We don't overlook anything these days. So, over to you, sir.
Well, let me see if I could actually break it down more easily. But what they call viral hemorrhagic fever is actually a scientific name for a group of illnesses. It's a group of illnesses that are caused by several family of viruses. So while in school, I know even viruses have families, how they react. It's based on is it their shape of capsid, something like that. Is it how they transmit? Is it how they do this? So it's just like how we are classified based on where we are, what we do. So that's how viruses are classified. So what it means is that viral hemorrhagic fevers are a group of illnesses that are caused by viruses, and also there are classes of viruses. I could already remember two as at now, maybe later. But for Lassa, I could remember very vividly that it's actually called Arena Viridae and also Filoviridae. And if I could remember, I think Ebola, Filoviridae have some mobility issues. And also Arenaviridae, they actually have some issues around how they could be mobility to people, transmission issues. But what they do is that those viral hemorrhagic fevers can really affect multiple organ system, and severity of those cases can disrupt a lot of issues. So they cause coagulation issues, meaning that they can produce bleeding manifestation. That's hemorrhagic. When we say hemorrhagic, is that they cause bleeding, they cause disruption of vascular integrity. So what really causes the bleeding is actually from when there's coagulation issues and also vascular integrity disruption. So with those viral hemorrhagic fever are different. I earlier said it, they are different in transmission and severity. Particularly Lassa. Lassa is most time very mild. You feel asymptomatic, you don't feel anything. And in most people, they don't see symptoms early. And the issue happens there. And that's why I say they are very, very deadly. Because if, for example, I have a fever, I have viral diseases, and you go to hospital, they actually then came up to say, let's do a viral testing. So the first key thing for what I know during my clinical practice is that they will start putting you on ceftriaxone. Ceftriaxone is more like how to dose bacteria or something, but it doesn't have effect on the fever. So the first key thing is that it marks the whole fever, so you start to feel better. But when that replications of that virus continue, so that minority issues or that asymptomatic issue will develop to what we call a severe diseases. And that severe diseases manifest in many ways. It causes bleeding. And I knew from my school, when bleeding is much, it causes shock, hemorrhagic shock, right? And also when we have hemorrhagic shock, it actually manifests in multiple organ failure. Your kidney, your liver, because that's where replication of virus happen in the liver. And also multiple organ, the brain. I know the CNS. I think I could remember the CNS. The whole CNS, your brain, the shock, your brain has issues. You have hemorrhagic shock. Your kidney, so those all organs actually fail. And you know how really expensive it is to have a failed CNS system or even multi-organ failure. So that's how deadly it is, because if it could have come as a normal symptoms, it can really be tested to say, oh, this is actually virus. Let's treat it. And like I said, we need to actually invest in diagnostic capacity, because these are diseases that actually goes off. You can't see it. And I actually read a story yesterday. I also can't remember it vividly. A friend who I know very closely sent a story that actually someone as a female, she actually had been out of home, I think, due to frustration. So she came back not feeling so well. And basically she was just going down her. She said, no, her parent need to take her to the hospital. They say no, that they felt she has HIV, might have contracted something. That see, they can't take her to hospital. It's a shame. She said, no, she's not getting fine. She's becoming so bad. They say, no, it's just HIV. She let her go to the hospital. They find out that she has diabetes. I think diabetes, which has actually has been trying to give her problem. But she has been stigmatized because she has symptoms. That's also even a bit better because she can be tested. But when people have the likes of Lassa, you don't have symptoms. People are just saying you just do it anyhow, and or you're just changing, and you go to the hospital, maybe a PSC or even a chemist, pharmacy. They don't really do those tests. They feel like this guy has something that we don't know. So that's really how it is. And also the problem majority is that the transmission rate, even if it is not the control measure, if it didn't happen strictly to IPC measure, you transmit it to someone. Because for example, like Ebola, or even the same, it actually you can spread it easily by bodily fluid. So Lassa is less easily transmitted. I think person to person, it's actually very less. But that nosocomial infections or transmission is a documented risk without a proper IPC. Like I said, it's actually different. Like Ebola is actually very highly transmitted person to person. And Lassa fever, I know the last thing I know is less easily transmitted, not really as high as others. But also some studies have shown that it can really be transmitted through that way. So when you don't have a proper infection prevention control, there is also a risk there. So I felt for clinicians and also policymakers and also people who have actually been working on what we call viral hemorrhagic fever, is to emphasize on the need for high suspicion when people actually come for disease or fever of unknown origin. I think that's what we say in school. Fever of unknown origin is actually to most times do viral testing, and also look around PPE, look around protective prevention equipment to do that. How do we wear our gloves and how do we do this? And basically, like also, we are actually pushing our health system setting. We actually start from bottom top approach from the primary healthcare. So it's something we need to actually talk around to the primary healthcare. Triage. I don't forget triage anytime I thought around infectious diseases. And also laboratory confirmations, very, very important, so that we don't create scenarios that someone will feel like, oh, this is actually something that reduces his confirmation or integrity on the health setting. And that's something trust we seems not to have, because people feel like, oh, a hospital told me I have Lassa fever. He goes somewhere and maybe the testing is not good. They say, no, you don't have this. So those are things that build trust to the system. So over to you.
Thank you so much for that, Mr. Wada. Our listeners, basically, next time you come across, he has explained it in depth. There is nothing for me to add. But next time you come across viral hemorrhagic fever, there's no viral virus, hemorrhagic bleeding. It has to do with blood bleeding, then fever. You know what fever is? Then your muscle pain and everything brings the symptoms associated with fever. So next time you come across viral hemorrhagic fever, it's not news. You learned it from this platform what it is basically. And it's not big English and big scientific language. So lastly, this is a question I sometimes ask guest researchers on this platform. What are the challenges you faced, you and your team faced during this research?
I think as basically like I said, or you actually alluded, is that I'm more of implementation policy person. We do a research more of implementation science, advocacy, and communication. So those three actually are the pivot for what we do policy. So we look for evidence. I think as a researcher, particularly in countries like Nigeria, There's actually issues around many things. I knew the ones I'll say here. It's most times around what we face as a country. Basically, sometimes we don't really give importance to research. People feel like it's actually more of an investigative journalism work, not really to provide evidence for better outcomes for policy making. For me, I felt one of the key things we faced was operational constraint during those outbreaks. So basically, I could remember vividly to even look around because, for example, when we were trying to get our sample representation, we actually need to deduce that from maybe the number of healthcare workers, maybe trained or even have training. I know for over 6 months, I actually was going to NCDC to ask for data around Lassa fever. And at some point, I actually have to get someone from there to tell her that, please, can you be part of this important paper so that you provide us with vital information. But for over 6 months, we couldn't get any information. And at that point, I felt things has improved now, but at that point, there wasn't even what we call the situation report, weekly situation report on Lassa fever. So you can only bank on states, that's the public health department, also the NCDC, to do that, because the validation does at the national level. State, even if they give you figures, might not really be what is in tandem with also the numbers they have. So that field work in outbreak setting was logistically hard for us, because imagine a state actually battling with validation of their figures and you're telling them to do this, or even staff being overburdened to actually do that. And I think access to some facilities were restricted for us, because basically people feel like, oh, why are you coming to do this? Is it investigative journalism? Which actually have some effect also. And I think collecting high quality data, but also a stretch, is something we're very keen on, to get as much data, because the first key thing when the doctors see that our sample was also put in pharmacists, radiographers. I could remember vividly someone say, no, he won't answer this. You're actually trying to do things that it won't give you a figure, a good data, because why are you putting pharmacists or radiologists who doesn't been there? But the whole health setting, they actually might have in contact with people who have that diseases, maybe drugs, and sometimes even therapeutic interactions. How do they be part of the whole processes? I think those are key things. The first key thing I think we actually face. The second thing was actually issues around self-report bias. And one of our own study was actually to make sure that we don't have a self-report bias. We make sure that at that point, someone just give us what he knows, because at some point we felt like, oh, this is actually a paper. How do we do this? How do we get this thing? They will tell you, oh, come back. They might be rigged. Someone will browse it. You understand? So we actually were on their toes to understand that, oh, this is something that requires careful interpretations, careful to understand that, oh, you know what it means, not that someone later will say, oh, he'll browse or something like that, so that it doesn't compound or have bias to what he wanted to do. So that's really something. And many participants overestimated their knowledge. You saw it, which might even complicate that interpretation. So even we actually anticipated that. So what we did was a very careful questionnaire design. And I know it's something I'm very proud of. We actually created one of the best questionnaire design and development. You could also see our reliability, our validity. We actually went to professors to say, oh, sit down together. We brought them together within our resource to say, oh, sit down to see that we have seen many questionnaires and we have seen lapses. We want as much as possible not to have that issue. Try as much to sit down to tell us, what do you think? After that phase validity, went to content validity, you could actually see it listed. And it's one of those trends that even our reviewers were happy. The review report is actually online on the journal. One key thing they were so happy is that, oh, this actually followed the whole pilot testing, and also ensures that that design and that input were very correct. So we actually reported that full analysis from the ICC to other analysis we did: reliability, content validity, face validity and others. The second is actually around laboratory and diagnostic limitations. We actually didn't work on go to laboratory access. We'll find out that even our policy recommendation was really linking clinical finding with confirmed cases. And something I saw a study have actually built upon. I think it was on BMJ Global Health or so. Funding at that time where we don't have any funding, so it was more of ourselves. Even through publication, we didn't get any funding to actually say, oh, let's do. So we actually in-house to do every funding. But one key thing is that we prioritize our research to say, oh, let's actually reduce any bias. Let's look at anything that will really help. The last thing I could say is around ethical and safety requirement. Even at some point that we felt at that research, we felt ethical issues were something, because even at when we're looking around ethical approval, at that time there was here and there, do they give us or not? Because it actually shows the vulnerability of even healthcare workers at that time. But we actually try as much to understand to them. We tell them that this is something that really improves their data, their trainings and tailored approach, and that signals a bit of rigor and responsibility from the institution. So I think those are a few challenges we faced, and we are here, and I think and I hope that this have really changed the course of how our health system and also how our healthcare trainings have really been reshaped. And one key thing I do say is that this study is not really about Lassa fever only. The recommendation cut across a lot of diseases, because if on Lassa fever we have for example, a knowledge overestimation or competency overestimation, it tells you that many diseases which have gone unnoticed can actually have the same thing. And it really calls for rigorous M&E to actually understand that are we having a fit for purpose workers, and also are we having the right fit knowledge, right fit experience, right fit expertise. So I think it's something we actually try to do.
Thank you so much, Mr. Wada, for sharing your time and expertise with us. Thank you for giving us a very, very insightful learning session. Actually, we've discussed for so long, I didn't even want the discussion to end. Thank you so much for giving us your time and your expertise, for sharing your time and your expertise with us. Global citizens, during the week we went through Mr. Wada's publication on Lassa fever in Nigeria. Currently, there is a surge of Lassa fever in Nigeria, and it's a good paper to read to know what is happening, what is being done currently in Nigeria. This is a platform where research misunderstanding, and the platform mantra is each one help one. Don't just hold the knowledge you're getting from here. Share with your family, share with your friends, discussions, and also improve your health. Basically, this platform is to improve health literacy, health awareness on what is happening, so that we'll have better health as current and future global citizens. Thank you so much once again, Mr. Wada, for your time, and have a blessed week, everyone.
So thank you so much. It's an honor to be here. Thank you so much.